Coming to the section of top 25 screenshot one-liners in cardiology. So this is for NEET PG. Evaporatin inhibits funny current. So we learnt there is something called funny current, pacemaker current. It helps in the phase 4 of cardiac pacemaker action potential. So evaporatin inhibits the funny current. Evaporatin is also a second line drug for angina management. Idioventricular rate is 40 per minute. Class 1A, Class 1C, Class 3 antiarrhythmic drugs cause QT prolongation. So Class 1A will be quinidine. Class 1C drug will be plicanide. Class 3 is amiodarone, dronidarone, etc. So Class 3 is a potassium channel inhibitor. Class 1 is a sodium channel inhibitor. So these two drugs, antiarrhythmic drugs, cause QT prolongation. Remember, Class 2 is beta blocker. Class 3 is Class 4 is calcium channel blocker. Mobitz type 1 AV block causes Wenckebach phenomenon, which is progressive prolongation of PR interval followed by a dropped beat. Inferior wall MI can cause AV block because inferior wall is supplied by the right coronary artery. Right coronary artery also supplies the right ventricle and right atrium. Also, SA node is also supplied by a branch from right coronary artery. So, inferior wall MI usually associated with right ventricular wall MI, posterior wall MI and conduction disturbances. Pulmonary embolism, the most common ECG finding is sinus tachycardia and the characteristic finding is S1Q3T3. Suspect pulmonary embolism when there is severe hypoxia in the background of some bedridden state or a surgery or malignancy with the DVT, and there is hypoxia disproportionate to their lung signs. So in our previous year NEET question discussion, this was discussed in question number 5. Narrow complex tachycardia with absent P wave and irregular RR interval is atrial fibrillation. Regular RR interval, it is AVNRT. So AVNRT treated with vagal maneuvers and adenosine. This was discussed in question number 4 of previous year NEET question series. For atrial fibrillation, rate control is the priority because in acute paroxysmal atrial fibrillation less than 48 hours alone, rhythm control is the priority. Otherwise, rate control is the priority, anticoagulation is next, and rhythm control is the last priority. This was also discussed in previous year NEET question series. Narrow complex regular tachycardia with absent P wave, but baseline ECG shows a Wolff-Parkinson White pattern, think of AVRT. Baseline ECG is normal, there is narrow complex regular tachycardia with absent P wave, think of AVNRT. Monomorphic VT occurs post MI. Polymorphic VT, that is torsionis depointus, occurs in QT prolongation. Hypokalemia, hypomagnesemia, hypocalcemia, all these things cause QT prolongation, plus many drugs cause QT prolongation. Congenital long QT syndrome cause QT prolongation. QT prolongation leads to polymorphic VT. Tall T wave occurs only in two conditions, hyperkalemia or hyperacute MI. Hyperacute MI, we call it as de-Winter's sign. This was discussed in question number 33 in detail. Mitral valve prolapse and HOCM, these two murmurs decrease with hand grip and increase with standing or Valsalva. Usually all murmurs increase with hand grip and decrease with standing, but think of the mnemonic vast hand. HOCM and mitral valve prolapse alone are two heart diseases which behave differently. Valsalva or standing will increase the murmur, whereas hand grip will decrease the murmur. Okay, D for decrease. HOCM and long QT syndrome, they are diseases which cause sudden death. Also we have Brugada syndrome. These are diseases which cause sudden death. This was discussed in question number 20. Infective endocarditis or papillary muscle rupture, these are the two common conditions which cause acute mitral regurgitation. Acute mitral regurgitation usually causes heart failure. Enterococci causes infective endocarditis following urological procedure. So there are different organisms causing community acquired native valve endocarditis, hospital acquired native valve endocarditis, early prosthetic valve endocarditis and late prosthetic valve endocarditis. So the 5 pillars of heart failure management are beta blockers, ACE inhibitor, ARB, ARNI and SGLT2 inhibitors. This was also discussed in one of the questions. In STEMI, first medical contact to PCI time is less than 90 minutes in PCI enabled centers. If for a referral center, the time is 120 minutes. Multivessel coronary artery disease, we prefer coronary artery bypass grafting either with the Lima graft, internal mammary graft, or with great saphenous vein graft. So convex ST elevation with reciprocal changes, it is MI. Concave ST elevation without reciprocal changes and with PR segment depression, it is acute pericarditis. If posterior descending artery of the heart arises from right coronary artery, it's called right coronary dominance. If posterior descending artery arises from the left circumflex, it is called as left dominant system. If it arises from both, it's called co-dominant system. Cardiac tamponade versus constrictive pericarditis, think of the mnemonic paid tax. In constrictive pericarditis, both X descent and Y descent are prominent, whereas in tamponade, only X descent is prominent, which means Y descent is absent. This was discussed in question number 21, and it was discussed in our complete cardiology revision series, also quick revision series. Stanford A or DBQ 1 and 2 aortic dissection is surgery because Stanford A, ascending aorta is involved. DBQ 1 is both ascending and descending aorta. DBQ 2 is only ascending aorta. So whatever it is, if ascending aorta is involved, the treatment is surgery. So these are some of our screenshot, 25 top screenshot one-liners. Welcome to the last minute pulse for NEET PG discussion in our channel Medicine Demystified. So we will discuss endocrinology. The prolactin is the only hormone from the anterior pituitary which has inhibitory influence from the hypothalamus. It has only inhibitory influence, that is from dopamine. Stalk effect is one cause of hyperprolactinemia, that is any tumor which is occluding the stalk, dopamine will not come from the hypothalamus to the anterior pituitary, so prolactin will increase. So that is called a stalk effect. It is one of the causes of hyperprolactinemia. And about the diurnal variation of hormones, serum cortisol, it peaks at 8 a.m. in the morning and troughs at 11 p.m. to 2 a.m. that is in the night. Now about stimulation test and suppression test. Glucose tolerance test is done to confirm acromegaly. When glucose is given, it stimulates insulin and it should suppress the growth hormone. So insulin should increase and growth hormone should decrease when given glucose. But in acromegaly, growth hormone will be high despite giving glucose. So glucose cannot suppress the excess growth hormone in acromegaly. The contrary will be in dwarfism, insulin stimulation test. On giving insulin, glucose will become low. Normally a low glucose should stimulate the growth hormone. But when there is dwarfism, growth hormone will be deficient even on giving insulin. So glucose tolerance test is for acromegaly, insulin stimulation test is for dwarfism. Similarly, ACTH stimulation test is done to confirm Addison's. When ACTH is given, normally cortisol should rise, but in Addison's disease, cortisol is deficient. It will not rise even on ACTH stimulation. And for Cushing's syndrome is excess of cortisol, we have to do a suppression test. That is overnight dexamethasone suppression test or low dose dexamethasone suppression test. These two suppression tests will confirm Cushing's disease. Now, what is this high dose dexamethasone suppression test? Once we have confirmed Cushing's disease, we have to find out whether the pituitary is producing ACTH or ACTH is produced from another tumor. So, high dose dexamethasone suppression test should suppress the pituitary adenoma, but it cannot suppress the ectopic ACTH. So, high dose dexamethasone suppression test, if there is suppression of ACTH production, it means it is a pituitary adenoma. If the high dose dexamethasone suppression test does not reduce the cortisol and ACTH, it means ACTH is ectopic. Syndrome of inappropriate excess anti-H, SIADH, causes hyponatremia because excess antidiuretic hormone reabsorbs more water through the aquaporin 4 channels and it dilutes the blood, leading to hyponatremia. So hyponatremia and hypotonicity of the blood. Whereas the opposite of this is diabetes insipidus, where there is deficiency of ADH. ADH is a posterior pituitary hormone. When ADH is deficient, water cannot be reabsorbed from the distal convoluted tubule and collecting duct. So water will be excreted. So urine will be dilute, but the blood will be hypertonic and there will be hypernatremia. So usually they say euvolemic hyponatremia is caused by SAADH. Euvolemic hypernatremia is caused by diabetes insipidus. Diabetes insipidus may be central or nephrogenic. Coming to thyroid, if TSH is high, then it means it is primary hypothyroidism. In primary hypothyroidism, T3, T4 will be low. Due to feedback mechanism, TSH will increase from the pituitary. There can be another possibility where there can be a secondary hyperthyroidism. That is, the problem is not with the thyroid gland, but with the pituitary. The pituitary is producing more of TSH, hence T3 and T4 is high. So these are the two possibilities when TSH is high. Either it is a primary hypothyroidism where T3, T4 is low, or secondary hyperthyroidism where TSH is high and T3, T4 is also high. The most common cause of primary hypothyroidism is autoimmune hyperthyroidism, and the most common cause of primary hyperthyroidism is Graves' disease. Primary here means the problem is with the gland itself. Now coming to feedback of the cortisol, mineralocorticoid production is not under the control of hypothalamo-pituitary-adrenal axis. It is under the control of renin-angiotensin-aldosterone, whereas the adrenal sex steroids and the adrenal glucocorticoid, that is cortisol, these are under the control of HP axis, that is by the ACTH. Mineralocorticoid is under the control of RAS system. Aldosterone is a mineralocorticoid. It acts by stimulating the epithelial sodium channel in the collecting duct. Also, it excretes potassium. So the function of aldosterone is to retain sodium and to excrete potassium. So in Cushing syndrome, we have moon face, buffalo hump, purple striae. This purple striae is very important. Proximal myopathy. These are the clinical features of Cushing's syndrome. Cushing's is actually cortisol excess. What happens in mineralocorticoid excess? Excess of mineralocorticoid is Conn syndrome. So Cushing's is excess of cortisol, Conn's is excess of mineralocorticoid. There, secondary hypertension, hypokalemia and alkalosis, because mineralocorticoid causes potassium excretion. Now primary Addison's disease. Primary Addison's disease means there is a problem in the adrenal gland itself. So when the gland itself is problematic, both glucocorticoid and mineralocorticoid secretion will be low, and ACTH will increase because cortisol is becoming low. This is by feedback stimulation. So when mineralocorticoid becomes low, there will be hypotension, hyponatremia, hyperkalemia. These are the opposite of mineralocorticoid excess. When ACTH is high, it will cause hyperpigmentation, and hypoglycemia is because of cortisol deficiency. So hypoglycemia is because of cortisol deficiency. Hypotension, hyponatremia, hyperkalemia is due to mineralocorticoid deficiency, and ACTH excess causes hyperpigmentation. So this hyperpigmentation is a very important feature of Addison's disease. Now another disease of adrenal is congenital adrenal hyperplasia, where there is a problem in an enzyme called 21-hydroxylase. Because of this, what happens is the sex steroids become high because cortisols are not produced. Mineralocorticoid and glucocorticoids are not produced. The entire pregnenolone is getting converted to adrenal androgens. So adrenal androgens are high, mineralocorticoids is low. So this causes virilization in females. Virilization in females or premature puberty in males. Pheochromocytoma is a problem with the adrenal medulla. Excess noradrenaline is secreted by the adrenal medulla. It is characterized by headache, palpitation, sweating, and episodic hypertension. Men 1, remember 3 P's: pituitary, parathyroid, and pheochromocytoma. Also remember another tumor which is gastrinoma. Whereas men 2A and 2B, there are many other tumors. Remember, medullary thyroid cancer is common in men 2A and men 2B. Semaglutide is a new drug which is a GLP-1 receptor analog. Tirzepatide is called twincretin. It is GLP-1 and GLP-1 analog. Both are latest treatment in obesity. Also, they can be used in diabetes mellitus. So, diabetes mellitus, we have type 1, 2, and 3. 3 has many numerical alphabetical subtypes. 3A is MODY, maturity onset diabetes of young. The commonest mutation is HNF4 alpha. 3C is pancreatic diabetes. 3E is endocrine diabetes. Diabetes definition is HbA1c more than or equal to 6.4, fasting blood sugar more than or equal to 126, postprandial blood sugar more than or equal to 200. Values in between will come under impaired fasting glucose or impaired glucose tolerance. This is hyperglycemia. For hypoglycemia, we have Whipple's triad. Whipple's triad is symptoms and signs suggestive of hypoglycemia. Hypoglycemia proved by testing, and the symptoms of hypoglycemia should reverse with glucose supplementation. There are many causes. For example, insulin excess or low intake of glucose is a cause, but insulinoma is also one of the causes. DKA is a hyperglycemic emergency or a diabetic emergency. It is defined by diabetic, that is, diabetes should have RBS more than 250. Ketosis is ketones more than 3 milligrams per deciliter. And acidosis is high anion gap metabolic acidosis. So DKA causes high anion gap metabolic acidosis with bicarbonate less than 18 milliequivalents per liter. Coming to dyslipidemia, we have many types. Type 2 hyperlipidemia is called as familial hypercholesterolemia. This causes tendon xanthomas. At least you can remember this one. Now hypercalcemia, that is about calcium balance. The important point to remember is hyperparathyroidism and paraneoplastic hypercalcemia. These are the two most common causes of hypercalcemia. Paraneoplastic hypercalcemia can occur either due to any osteolytic or osteoblastic secondaries, or it could be any bone marrow tumors like multiple myeloma, or some tumors due to paraneoplastic reaction can secrete parathyroid hormone related peptide. Example is squamous cell carcinoma of the lung. CKD causes secondary hyperparathyroidism. Primary hyperparathyroidism is the parathyroid gland is secreting more of parathyroid hormone. Secondary hyperparathyroidism is, in CKD what happens is PTH phosphate will be high because phosphate is not excreted. High phosphate is the main stimulus for parathyroid secretion than low calcium. So this high phosphate stimulates parathyroid hormone secretion from the gland. This is called secondary hyperparathyroidism. When hyperparathyroidism occurs, it draws the calcium from the bone into the blood. So the bones become thin, fibrotic, and painful. That is called osteitis fibrosa cystica. Good morning. Today in our last minute revision series for NEET PG, we will discuss about 25 one-liners from neurology. So crossed hemiplegia or crossed hemianesthesia syndromes mean the involvement is in the brainstem. Paraparesis or quadriparesis, it may mean there is a problem with either the spinal cord or it is a polyradiculoneuropathy. Example for polyradiculoneuropathy is GBS, that is involvement of nerve root as well as nerve. If there is involuntary movement, think of basal ganglia. Now we localize basal ganglia. Chorea is a problem with the caudate nucleus. Athetosis is a problem with the globus pallidus. Wing beating tremors, which occurs in Wilson's, it's a problem with the lentiform nucleus. Hemibalismus is a problem with the subthalamic nucleus. Parkinsonism is a deficiency of dopamine in the substantia nigra pars compacta. If there is a pure motor weakness, that is without any sensory involvement, think of neuromuscular junction, muscle, anterior hornsel of the spinal cord, or the upper motor neuron. That is called as motor neuron disease. It could be lower motor neuron disease or upper motor neuron disease. There is pure motor weakness. Now about the cerebrum. Broca's area is present in the inferior frontal gyrus. It is area number 44. Problem with this Broca's area causes motor aphasia or non-fluent aphasia. Wernicke's aphasia is area 22, which is present in the superior temporal gyrus. Stroke here or a problem here will cause fluent aphasia or sensory aphasia. It's a problem with the comprehension, whereas Broca's aphasia is a problem with word output or fluency. So in stroke, we have ischemic stroke and hemorrhagic stroke. Ischemic stroke presenting less than 4.5 hours, that is the window period. We have to prefer alteplase thrombolysis. In some cases we don't do, but we prefer alteplase thrombolysis. 4.5 hours to 24 hours time window, we cannot do thrombolysis, but we do mechanical thrombectomy. CT brain is the best immediate step in stroke imaging because it is time saving, but MRI is the best imaging overall for stroke. In subarachnoid hemorrhage, we have two types, aneurysmal SAH and traumatic SAH. Aneurysmal SAH commonly occurs due to beryaneurysm. When it ruptures, there will be SAH. This beryaneurysm or aneurysm is common in the posterior communicating artery. It will be close to the third nerve. And beryaneurysm is also common when autosomal dominant polycystic kidney disease. So one drug which we have to remember is nimodipine. Nimodipine is important in SAH to prevent cerebral vasospasm. Epidural hemorrhage in trauma, it will be biconvex shape. Subdural hemorrhage will be concave shape. Coming to cranial nerves, important points are, if the entire half of the face is involved, it is LMN facial palsy. Example is Bell's palsy. And if you think of some brainstem syndromes, there will be crossed hemiplegia. In that Millard-Gobler syndrome or Foveli syndrome, these syndromes are LMN facial palsies. They involve the entire half of the face. Only if the lower part of the face is involved, it is UMN facial palsy, occurs in stroke, cortical or internal capsule involvement. Now about the third nerve, diabetic third nerve palsy, there will not be pupillary dilatation. Aneurysmal third nerve palsy, there will be pupillary dilatation because in aneurysm there will be compression. Pupillary fibers are peripheral. Whereas in diabetic palsy, only the core is affected, the central part of the nerve is affected, but pupillomotor fibers are peripheral, so pupillary fibers are spared. About seizures, we have two types, focal onset seizures and generalized onset seizures. Focal onset seizures, the drug of choice as per Harrison is lamotrigine or carbamazepine. For generalized onset seizure, drug of choice is lamotrigine or sodium valproate. Remember sodium valproate here. Typical or atypical absence seizure, sodium valproate. So except in focal onset seizure, sodium valproate comes everywhere. If there's a generalized tonic-clonic seizures, status epilepticus. So if there is a GTCS which is producing a status epilepticus, first we should give IV benzodiazepine like midazolam or lorazepam. If it fails, then we have to give IV anti-epileptic drug which could be phenytoin or fosphenytoin or levetiracetam or sodium valproate. Still if it continues, we should give benzodiazepine infusion. Still if it continues, we should give thiopentone, that is barbiturate infusion. Last step, we should go for general anesthesia. About headaches, one important type of headache is cluster headache. It lasts for 15 minutes to 3 hours. Timing is important because in migraine, the time duration is 4 hours to 3 days. In cluster headache, it is 15 minutes to 3 hours. Treatment is oxygen, sumatriptan injection. Prophylaxis by verapamil, topiramate, melatonin and galcanezumab, which is a monoclonal antibody against calcium sensing receptor. Coming to the neurodegenerative diseases, Alzheimer's disease is a tauopathy. It progresses as memory loss followed by behavioral disturbances. This is important because if behavioral disturbance comes first, we have to think of frontotemporal dementia. Treatment for Alzheimer's is cholinesterase inhibitors, that is donepezil, rivastigmine and memantine. They increase acetylcholine in the brain, thus helping with memory. Parkinsonism is a tetrad consisting of bradykinesia, rigidity, resting tremor and postural instability. Parkinson's disease is one of the diseases which have Parkinsonism. It is a neurodegenerative disease where synuclein gets deposited. Parkinson's plus is an atypical Parkinsonism which has some features in addition to these four, and there is poor response to levodopa. So the types are Lewy body dementia, corticobasal degeneration. In Lewy body dementia there will be dream delusions, etc. Corticobasal degeneration there will be cortex, so Alzheimer's, that is memory loss plus Parkinson's. Multiple system atrophy is of two types, MSAC and MSAP, and we have PSP, progressive supranuclear palsy, where there will be eye changes, eye movement changes. So what are the MRI findings? Parkinson's disease, we have loss of swallowtail sign. Swallowtail is the normal substantia nigra. When it is less in dopamine, there will be loss of that tail. MSAC will have hot cross bun sign. MSAP will have putaminal ring hyperintensity. Progressive supranuclear palsy will have hummingbird sign. Now coming to demyelinating diseases, multiple sclerosis. Multiple sclerosis is CNS demyelination. Multiple sclerosis is a relapsing remitting disease. Optic neuritis is typical here, and if you do lumbar puncture, we have oligoclonal bands. Neuromyelitis optica or Devic disease is also a CNS demyelination, but contrary to multiple sclerosis, it's a single phase disease. It occurs only once. Here the classical features are optic neuritis and transverse myelitis, especially longitudinal extensive transverse myelitis. Here there is a good steroid response. In multiple sclerosis, only in few cases steroid response will be there. Here we see aquaporin in lumbar puncture. Guillain-Barré syndrome is a peripheral nervous system demyelination. Here the classical clinical picture is ascending paraparesis, usually follows a diarrheal disease, especially caused due to Tauferema vipelli. In nerve conduction study, we get demyelination pattern. What is demyelination? Myelin is needed for fast conduction in neurons. So when demyelination is there, conduction velocity gets slowed. Conduction velocity becomes slow, and we have something called as F wave latency, that is also prolonged. Actually latency is prolonged because the impulse takes time to get propagated. So that is the finding in nerve conduction study. If you do an LP, we have cytoprotein dissociation, that is protein will be high but cells will be low, lymphocytic cells will be low. Treatment here is IVIG or plasmapheresis. Now coming to the pure muscular diseases, a disease of neuromuscular junction is myasthenia gravis. It is an autoimmune disease where there are blocking antibodies against the acetylcholine receptor. Acetylcholine receptor is a postsynaptic receptor. Sometimes if acetylcholine receptor antibody is negative, usually acetylcholine receptor positivity is seen in 85% cases. In the remaining 15% cases, we may have anti-musk antibody positive. The classical clinical picture is fluctuating fatigable weakness. If you do a repetitive nerve stimulation or single fiber EMG, the response is decremental response, because as we keep on stimulating the muscle, acetylcholine gets utilized and muscle contraction will be slowed. Treatment, initial thing is pyridostigmine, which is a cholinesterase inhibitor. So we can increase the acetylcholine in the neuromuscular junction. Steroids can be given because it's an autoimmune disease. Immunosuppressants, thymectomy, because many cases of myasthenia gravis are associated with thymoma. Close DD for myasthenia gravis is LEMS, Lambert-Eaton myasthenic syndrome. It is a paraneoplastic disease which occurs secondary to small cell lung cancer. Small cell lung cancer produces an antibody which is called VGCC, that is antibody against the voltage gated calcium channel of the presynaptic membrane. So myasthenia gravis is postsynaptic, LEMS is a presynaptic problem. So here there is an incremental response on repetitive nerve stimulation. Being a paraneoplastic disease, we have to remove the antibody. Treatment is plasmapheresis or IVIG. Now the next pure motor disease is a motor neuron disease. The most common motor neuron disease is amyotrophic lateral sclerosis. Here we have mixed LMN and UMN pattern. There are MNDs with pure LMN. There are MND with pure UMN. ALS is a UMN plus LMN disease. Here it is a TDP4 related disease. Here there is a deficiency of sodium oxide dismutase enzyme. So free radicals get accumulated which damages the nerve. So the treatment here is riluzole and edaravone. They are basically free radicals. So they scavenge the free radicals and prevent the nerve injury. Now next is myopathy, muscle dystrophies, creatine kinase will be elevated. It's a muscle problem. Now about meningitis, when you do CSF, if there is a lymphocytic CSF, see the protein and glucose. If there is lymphocytic CSF plus high protein and low glucose, it means there is tuberculous meningoencephalitis. TB bacteria utilize the glucose and it produces many proteins. But if there is a lymphocytic CSF with a normal protein and normal glucose, which means it is not a living organism, so glucose is not utilized, protein is not produced. It is viral meningoencephalitis. In immunocompromised patients, if there is a lymphocytic CSF, always we have to do India ink stain to look for cryptococcal meningitis. So welcome to our channel Medicine Demystified MD. We are discussing last minute polls for NEET PG. Today we will discuss pulmonology. So the pulmonology basics is FEV1 by FVC. This ratio is reduced in obstructive airway disease. Why it is reduced in obstructive airway disease? FEV1 is low, FVC is normal, so the ratio is reduced. Whereas this ratio is normal in restrictive lung disease because both FEV1 and FVC are reduced to the equal amount. So even though FEV1 and FVC are reduced, the ratio is normal. So that is FEV1 by FVC ratio is more than 80% in restrictive lung disease. It is less than 80% in COPD and less than 70% in bronchial asthma. So less than 80% in bronchial asthma, less than 70% in COPD. In pure ventilation disorders, so these are some physiological concepts. COPD is a pure ventilation disorder. Giving hypoxia will improve oxygen. Whereas in ventilation perfusion mismatch, so example for ventilation perfusion mismatch is pulmonary embolism. Here, ventilation, that is air entry into the lungs is normal, but the blood supply to a particular segment of the lung is abnormal because perfusion is affected by embolism in the lung, pulmonary embolism. Here, giving oxygen will not improve the hypoxia. So even though there is hypoxia, in ventilation disorders, hypoxia will improve. Ventilation perfusion disorders, hypoxia will not improve. This is important physiological concept which will help us to understand the pathogenesis of pulmonary embolism. Told you in bronchial asthma, FEV1 by FVC is less than 80%. Bronchial asthma is an obstructive airway disease, but here there is bronchodilator reversibility. That is, on giving bronchodilators, the reduced FEV1 will improve by more than 20%. Whereas in COPD, here again FEV1 by FVC is less than 70%, but there will not be bronchodilator reversibility. Also in bronchial asthma, inhaled corticosteroids are the main pathology changing drugs. The pathology changing drugs in asthma are called as controllers. So inhaled corticosteroids are the controllers. Whereas we have another group of drugs called as relievers. They only cause bronchodilation, but they don't change the inflammatory pathology. So they are short-acting beta agonist, example salbutamol or levosalbutamol, short-acting muscarinic antagonist, that is ipratropium, long-acting beta agonist, that is formoterol, indacaterol, etc. And we have long-acting muscarinic antagonist, they are tiotropium. Coming to occupational lung diseases, asbestosis is important because it affects the pleura. Initial stages there will be pleural plaques. Later stage there will be mesothelioma, which is a tumor of the spindle-shaped cells of the pleural cavity. Silicosis usually affects miners, construction workers, etc. It causes lung fibrosis of the upper lobe. Lung fibrosis of the upper lobe is typical for tuberculosis. Silicosis mimics TB, also it is associated with tuberculosis. Now coming to another disease, cystic fibrosis is a disease which usually causes bronchiectasis. Bronchiectasis is also an airway disease where there is a destruction of the permanent destruction and dilatation of the airway. Destruction and dilatation of the airway will lead to stagnation of secretions and further infection. So cystic fibrosis, there is mutation of CFTR, that is cystic fibrosis transmembrane receptor channel, which is a chloride channel. The commonest mutation is deletion of phenylalanine of 508. That's called delta 508 deletion. This is the most common mutation. Now, alpha-1 antitrypsin deficiency is one cause of emphysema. It is actually a cause of emphysema plus cirrhosis. The emphysema here is panlobular emphysema, whereas in COPD we get emphysema that is centri-acinar or centrilobular emphysema. Only the airway close to the central bronchi will be destroyed and dilated in centrilobular emphysema. That is common in smoking. Whereas pan-acinar emphysema is seen in alpha-1 antitrypsin deficiency. So we discussed in asthma, bronchial steroids, that is inhaled corticosteroids, are the main pathology changing drugs. Whereas steroids are not indicated in COPD. They are indicated in COPD only in certain situations. One is asthma COPD overlap. It is a special condition. Eosinophilia is there in COPD because steroids reduce eosinophilia, or when there is frequent exacerbations. Frequent exacerbation is more than 2 exacerbations in 1 year. So this was about airway diseases. Now coming to interstitial lung disease, the most common one is the idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is the disease name. If you see the pathology, that pathological finding is called as UIP, usual interstitial pneumonia. In contrast, we have another pneumonia that is non-specific interstitial pneumonia. It comes in secondary ILD, that is any systemic disease like SLE causing ILD. But rheumatoid arthritis causes UIP pattern only. This IPF has reticulonodular pattern and honeycombing. Honeycombing is typical of UIP or idiopathic pulmonary fibrosis, whereas NSIP, non-specific interstitial pneumonia, is ground glassing. So ground glassing is we are able to see the airways through opacity. Honeycombing is IPF or UIP. Ground glassing is NSIP. So in IPF, what we give is antifibrotic agents. They are nintedanib and pirfenidone. Pirfenidone and nintedanib. These are the drugs used in IPF. Whereas NSIP, we use steroids and immunosuppressants because NSIP is commonly associated with autoimmune diseases except RA, because rheumatoid arthritis is associated with UIP. Now about pleural diseases, pleural effusion, Light's criteria, that is pleural fluid protein by serum protein should be more than 0.5. Pleural fluid LDH by serum LDH should be more than 0.6. Pleural fluid LDH should be more than 2/3 of the upper limit of normal. The normal LDH is, upper limit of normal LDH is 300 international units per liter. So 2/3 of the upper limit of normal will be 200 international units per liter. So if the pleural fluid LDH is more than 200, that is also a criteria. So any of this is exudative effusion. If any of this is positive, the pleural effusion is an exudative effusion. There are many causes of exudative effusion. Rheumatoid arthritis and connective tissue disorders cause exudative effusion, but the specific one is very low glucose bilateral exudative. Sorry, I made it wrong here. It is bilateral exudative pleural effusion. Usually, bilateral effusion will be transudatic. Example in heart failure, CKD, hypoproteinemia, etc. But exudative is usually unilateral. But a condition where we get bilateral exudative pleural effusion is rheumatoid arthritis. Now about the other pleural disease, which is tension pneumothorax. It's not pneumothorax, it is tension pneumothorax. It's an emergency. Why it is an emergency? It causes hypotension, elevated JVP and absent breath sounds, because when lungs get collapsed due to tension pneumothorax, the lungs will not get filled. So JVP will be elevated and blood will not enter from the lungs to the heart. So there will be hypotension. The treatment is immediate needle thoracostomy followed by ICD. And about mediastinal tumors, at least if you remember, thymoma is an anterior compartment tumor, that is enough. Now a disease about point about obstructive sleep apnea. It is diagnosed by sleep study, also called as polysomnography. What we measure in polysomnography is an index called as AHI, apnea hypopnea index. So it measures the number of apnea hypopnea events in 1 hour. If the AHI is 5 to 14, it's mild OSA, 15 to 29 is moderate OSA, 30 or more is severe OSA. When thinking about OSA, we should know about the recent FDA approved drug for OSA, which is tirzepatide. Tirzepatide is a GLP-1 and GIP receptor analog, which is used in diabetes as well as obesity. It is the latest advancement. It's an injectable drug. It is FDA approved for OSAs because obesity is the commonest risk factor for OSA. So if patients having OSA, we have to give tirzepatide. OSA is also called sleep disordered breathing. The most common cause of lung transplant is COPD still. And about ARDS, a criteria called Berlin's criteria is used to diagnose ARDS. ARDS is actually non-cardiogenic pulmonary edema. It clearly gives. That is, there is pulmonary edema in X-ray, but there is no elevated pulmonary capillary wedge pressure. So, pulmonary edema like picture in X-ray plus pulmonary capillary wedge pressure should be less than 18 millimeters of mercury. The criteria, that is Berlin's criteria, is there should be low PF ratio less than 300. If it is 200 to 300, ARDS is mild. 100 to 200, ARDS is moderate. Less than 100, ARDS is severe. The second criteria is the onset of this hypoxia should be less than 1 week of a disease. The third thing is there should be bilateral lung infiltrates, which should not be explained by any other finding. So how will you treat ARDS? Is a ventilation strategy, that is low tidal volume and optimal PEEP. Some books say it is high PEEP, but the actual wording is optimal PEEP. So low tidal volume, high or optimal PEEP is the strategy because this prevents volume trauma to the lung. Now about pulmonary hypertension. When do you say pulmonary hypertension? Mean pulmonary artery pressure more than 20 is pulmonary hypertension. What is portal hypertension? Portal vein pressure more than 10 millimeters of mercury is portal hypertension. So pulmonary artery pressure more than 20 is called pulmonary artery hypertension, and pulmonary vascular resistance more than 3 Wood units is pulmonary hypertension. It is of 4 groups, group 1, 2, 3, 4. Group 1 pulmonary hypertension includes primary pulmonary hypertension due to congenital heart disease, and pulmonary hypertension associated with connective tissue disorder. Group 2 pulmonary hypertension is pulmonary hypertension due to left atrial dilatation, that is pulmonary hypertension due to left heart diseases. Group 3 pulmonary hypertension is pulmonary hypertension due to chronic lung diseases and chronic hypoxia like ILD, bronchiectasis, COPD, obstructive sleep apnea. Group 4 pulmonary hypertension is chronic thromboembolic pulmonary hypertension. Now about lung tumors. Small cell carcinoma is very important because it causes most of the paraneoplastic manifestation like Lambert-Eaton myasthenic syndrome. It can cause SAADH and hyponatremia. But squamous cell carcinoma is the only carcinoma in the lung which causes paraneoplastic hypercalcemia. So all paraneoplastic manifestations in lung are due to small cell carcinoma except paraneoplastic hypercalcemia, which is due to squamous cell carcinoma because this cancer secretes PTHRP, parathyroid hormone related peptide. About pneumonia, one point to remember very much is whatever be the cause of pneumonia, be it a community acquired outpatient pneumonia, an admitted community acquired pneumonia, hospital acquired pneumonia, ventilator acquired pneumonia, or a HIV person having pneumonia, or an immunosuppressed person having pneumonia, the most common cause of pneumonia overall is Streptococcus pneumonia. Okay. Other pneumonia should be suspected in specific situations. For example, Legionella pneumonia should be suspected when there is history of exposure to AC or a travel or some cruise. Pseudomonas aeruginosa should be suspected when there is any pre-existing lung disease like bronchiectasis or when there is a COPD. Any previous lung disease, if there is a pneumonia, think of Pseudomonas. Welcome to our channel Medicine Demystified MD. We are discussing last minute pearls for NEET PG in the subject of gastroenterology. So dysphagia and odynophagia are esophageal symptoms. Melena hematemesis are upper GI symptoms. So melena and hematemesis is upper GI bleeding. Melena is altered blood through the stools, that is black tarry stools. Hematochezia is fresh blood through the anus. So hematochezia indicates a lower GI pathology. Melena indicates an upper GI pathology. So about diagnostic colonoscopy, a therapeutic colonoscopy and diagnostic colonoscopy. So what are the uses of diagnostic colonoscopy? It is used for cancer screening. That is very important point. And one of the evaluation of anemia should include diagnostic colonoscopy, and diarrhea evaluation also should include colonoscopy, because diarrhea is actually a small intestine or a large intestine symptomatology. Like dysphagia and odinophagia is for esophagus, diarrhea is for either the small intestine or large intestine. Now what is capsule endoscopy? So we have upper GI endoscopy, which visualizes the esophagus, stomach and the up to the second part of duodenum. Colonoscopy visualizes the rectum up to the entire part of the cecum. But to visualize the jejunum and ileum, we have to use capsule endoscopy. So there are two uses of this capsule endoscopy. One is obscure bleeding. That is, we cannot visualize the source of GI bleeding through upper GI endoscopy or colonoscopy. We have to do capsule endoscopy. And next is the suspected Crohn's disease of the intestine, because the commonest part of the GIT involved in Crohn's disease is ileum. So screening colonoscopy is one use of diagnostic colonoscopy. For an asymptomatic individual, it is suggested to be done every 10 years to pick up any colonic pathology like a colonic polyp or colonic CA. If they have some high risk, that is a prior inflammatory bowel disease like ulcerative colitis or Crohn's, or if they have familial adenomatosis polyposis, if there's a family history of FAP, it should be done annually. For FAP, it should begin at a particular age. There is another familial colonic syndrome, colonic cancer syndrome, that is HNPCC, hereditary non-polyposis colon cancer, also called as Lynch syndrome. Here, the colonoscopy is done every 2 years after 15 years of age. Okay, now coming to esophagus, we have 3 esophageal motility disorders. One is achalasia cardia, nutcracker esophagus, and diffuse esophageal spasm. This diffuse esophageal spasm causes a finding called as corkscrew esophagus in barium swallow. What finding we get in achalasia cardia is bird beak sign. That is, the distal part of the esophagus is narrow. There will be proximal dilatation because the distal myndric plexus fails to relax. Esophageal cancer causes a similar sign called as rat tail sign. In bird beak sign, the distal narrowing of the esophagus will be uniform. In rat tail sign, the distal narrowing of the esophagus will be irregular. We have a new group of drugs next to even better than proton pump inhibitors, that is PCABs, potassium competitive acid blockers. Since they are competitive, they are reversible. They are not hit and run drugs like PPIs. So vonoprazan and fexupressin are the drugs. Helicobacter pylori is a very important infection which causes gastritis. It causes refractory acute gastritis, chronic gastritis. Chronic gastritis can lead to gastric cancer. And since it is an infection, there is always a lymphocytic infiltration of the stomach when there is a H. pylori infection. So it can lead to gastric maltoma. It is said that gastric maltoma reverses on treating only H. pylori. H. pylori can be diagnosed non-invasively or invasively. Non-invasively is by doing a stool antigen test, by doing a serology, urea breath test. Urea breath test is a sensitive and specific test, non-invasively. We can do biopsy, and endoscopically also we can do rapid urease test. So this rapid urease test and urea breath test are sensitive and specific tests. How will we treat Helicobacter pylori? There are so many regimens. Few common named regimens are clarithromycin triple, that is a PPI plus clarithromycin plus amoxicillin. Bismuth quadruple, where bismuth comes and metronidazole comes. Levofloxacin triple, load. Load is also levofloxacin, and doxycycline will be given there. So coming to dyspepsia evaluation, when in dyspepsia always look for alarm symptoms, that is more than 40 years, presence of anemia with dyspepsia, weight loss plus dyspepsia, GI bleeding plus dyspepsia, that is a melena or hematochezia or hematemesis. Fever plus dyspepsia, always we must do GI endoscopy to rule out stomach cancer, gastric cancer. Now, gastrinoma should be suspected when there is multiple ulcers, diarrhea, and ulcers in unusual locations. Multiple ulcers, because gastrin is more, so it causes more ulcers. Excess gastrin destroys trypsin, so protein is not digested, fats are not digested, so it leads to diarrhea. And there will be ulcers in unusual locations. So if these are there, we should suspect gastrinoma. Gastrinoma is a part of MEN1 syndrome. So there will be family history of pituitary, pancreatic, or parathyroid cancer. There are two types of atrophic gastritis. One is chronic atrophic gastritis type A. A is for autoimmune. Type B, chronic gastritis or chronic atrophic gastritis, is H. pylori related. Now coming to small intestinal diseases. Small intestinal diseases cause diarrhea and malabsorption. One important disease to remember in malabsorption is celiac disease. So the key terms to remember here is there is gluten intolerance. The antibody which is seen is anti-tissue transglutaminase IgA. It involves the duodenum. Why this word duodenum is important? Duodenum is the site of iron absorption. So celiac disease, there will be iron deficiency. If you do a biopsy, there will be villous atrophy. So duodenum, villous atrophy causing iron deficiency. How will you treat? Gluten-free diet is the first step. We can use steroids. Now another infection which causes malabsorption is Whipple's disease. Of course, there are other infections also which can cause malabsorption like Giardia. So presence of these worm infestations, we call it as tropical sprue. So these are some infections which cause diarrhea. Now coming to inflammatory bowel disease. We have two inflammatory bowel disease. One is ulcerative colitis, another is Crohn's disease. Let us differentiate them. Ulcerative colitis, smoking prevents the disease. Very important to remember. The organs involved here are rectum, sigmoid, and the descending colon, the left side of the colon. It is a continuous lesion and submucosal lesion. So since it is submucosal, it will not cause any strictures. Crypt abscesses are the pathological finding. Toxic megacolon is the complication. Crohn's disease is opposite to ulcerative colitis. Smoking increases the risk. Here the right side of the colon and small intestine is involved. So ileum is the commonest organ involved. Rectosigmoid is commonly involved in ulcerative colitis. Ileum is commonly involved in Crohn's disease. Skip lesions are seen. Continuous lesions are there in ulcerative colitis. Skip lesions are there in Crohn's disease. Submucosal involvement is there in ulcerative colitis. Here transmural involvement is seen in Crohn's disease. Because of transmural involvement, strictures are common. The pathological finding is cobblestone appearance. In ulcerative colitis, it was crypt abscess. And we have non-caseating granuloma. One of the diseases which causes non-caseating granuloma is Crohn's disease. Caseating granuloma, we know it is TB. The complication here is strictures because of transmural involvement. Don't confuse IBD, that is inflammatory bowel disease, with IBS. IBS is irritable bowel syndrome, which should be brought into the picture only when all other disease entities are ruled out. So we have a specific criteria, that is Rome 4 criteria for IBS, that is there should be abdomen pain once in a week for 3 months. There should be abdomen pain once in a week for 3 months, plus they should have symptoms related to defecation, that is symptoms can be increased or decreased with defecation. There should be change in the form of the stools or change in consistency of the stools, frequency of stools. This is the criteria for IBS. Mesenteric ischemia, remember the symptom is postprandial angina because it's a artery or venous related disease. Whenever we tell about malabsorption, we should have specific test. So carbohydrate, see point number 23. D-xylose test is the carbohydrate malabsorption test. 72-hour fecal fat estimation test is for fat malabsorption. One important disease causing fat malabsorption is chronic pancreatitis. Chronic pancreatitis causes two important diseases. One, it can cause type 3 D diabetes due to endocrine deficiency, and it cause exocrine deficiency. Sorry, it is 3C. It can cause exocrine deficiency where chymotrypsin is deficient, so it causes fat malabsorption. So we discussed about IBS. One antibiotic which is used to treat IBS is rifaximin. Rifaximin we know is a non-absorbable antibiotic which is used in hepatology as a prophylactic for hepatic encephalopathy, because it is being an antibiotic, non-absorbable antibiotic. When taken, it destroys the gut bacteria. So when gut bacteria are destroyed, those bacteria cannot convert the stool proteins into ammonia. So ammonia production is less. That is why it prevents hepatic encephalopathy. But now it is also used in rifaximin, especially to treat the diarrhea variant. So we should remember two important diseases which are used in cystic fibrosis as well as in constipation IBS. They are lubiprostone and linaclotide. Lubiprostone is a CFTR activator. CFTR is a chloride channel. So lubiprostone is a CFTR activator. Linaclotide is a guanylyl cyclase stimulator. Both increase secretions, hence they reduce constipation. Welcome to our channel Medicine Team Mystified MD. We are discussing last minute pearls for NEET PG. So we'll discuss hepatology today. When do you suspect alcoholic liver disease? Alcoholic liver disease should be suspected when a male has consumed more than 60 grams of alcohol per day and a female has consumed more than 40 grams of alcohol per day. So we'll see some diseases and the tests used to diagnose that. Wilson's disease, always see reduced ceruloplasmin less than 25 milligrams per deciliter. There is increased urine copper excretion. Copper gets deposited in liver, so liver copper estimation by biopsy. This is the gold standard. The drug used is D-penicillin. So the other term for this Wilson's disease is hepatolenticular degeneration, where liver gets affected first, then the lentiform nucleus of the brain gets affected. It leads to wing beating tremors. The eye finding we get is cataract, sunflower cataract, as well as KF ring, Kaiser-Fleischer ring. So hemochromatosis is another disease where iron gets deposited. So here there is elevated serum ferritin, there is elevated transferrin saturation. Transferrin saturation is nothing but iron by total iron binding capacity. If ferritin is high and transferrin saturation is high, in the case of cirrhosis, do HFE gene mutation. Treatment here is desferrioxamine. Now about autoimmune hepatitis, we have two types of autoimmune hepatitis, type 1, type 2. Type 1, we have anti-SMA antibody, that is anti-smooth muscle antibody. Autoimmune hepatitis type 2, we have anti-LKM1 antibody, liver kidney muscle antibody. Now we have two diseases which cause intrahepatic cholestasis, two autoimmune diseases which cause intrahepatic cholestasis. One is primary biliary cirrhosis, in which anti-mitochondrial antibody is positive, and another condition is primary sclerosing cholangitis, which is usually associated with Crohn's disease. Here P and K are AACS positive. P and K is the antibody which is seen in Church-Strauss syndrome. AACS is anti-Saccharomyces cerevisiae antibody. Alpha-1 antitrypsin deficiency, we know that we have cirrhosis and panlobular emphysema, so diagnosed by alpha-1 antitrypsin levels. Hepatocellular carcinoma is diagnosed when AFP, alpha fetoprotein, is more than 500 nanograms per ml, and there should be positive triple phase contrast CT. It is the specific scan which is used to diagnose hepatocellular carcinoma. MASLD is increasingly seen now, that is metabolic associated steatotic liver disease. The old term was this for fatty liver or NASH. Now they have removed these terms. We say MASLD when there is fat accumulation in liver plus one finding of metabolic syndrome. There are 5 criteria for metabolic syndrome. Even if one is present with fatty liver, it can qualify as MASLD. That is TGL, triglyceride more than 150 milligrams per deciliter, BP more than 130/85, or they should be taking medicines for hypertension. Fasting blood glucose more than 100 milligrams per deciliter, or they should be taking medicine for diabetes. HDL less than 40, for males or less than 50 for females. Waist circumference more than 90 centimeter in males or more than 80 centimeter in females. Any of this plus fatty liver will be MASLD. Suppose if they take alcohol, that is called MET-ALD, metabolic and alcoholic liver disease. So regarding interpretation of LFT, we have to classify into cholestatic pattern or hepatocellular pattern. In cholestatic pattern, ALP will be elevated, direct bilirubin will be elevated, GGTP will be high. The conditions causing this are primary biliary cirrhosis, primary sclerosing cholangitis, which we just discussed, and surgical conditions causing obstruction and drug-induced cholestasis. All other diseases should be suspected when there is a hepatocellular pattern. The third pattern which we see in LFT is isolated hyperbilirubinemia, which could be isolated indirect hyperbilirubinemia or isolated direct hyperbilirubinemia. If there is an isolated indirect hyperbilirubinemia, think of either hemolysis or congenital hyperbilirubinemias. So the two conditions which we must remember for isolated indirect congenital hyperbilirubinemia are Crigler-Najjar syndrome, there is type 1, type 2, which occurs in pediatrics. Gilbert syndrome is commonly seen in adults. If there is isolated direct hyperbilirubinemia, we have only two diagnoses, Dubin-Johnson syndrome and Rota syndrome. There are still others, but we are not discussing that. Coming to hepatitis infection, so think of the points. Hepatitis A is most common, food and waterborne, there is a vaccine available. Hepatitis C is also food and waterborne. Why it is important is it causes fulminant liver failure in pregnancy. Hepatitis B, we should know the serology. So we have two antigens and two antibodies. HBsAg, that is surface antigen positivity, indicates infection. HBeAg, that is envelope antigen positivity, indicates active replication. This correlates with HBV DNA levels. Hepatitis B is a DNA virus. Anti-HBC IgM, the antibody, first antibody is anti-HBC IgM. Always IgM indicates acute infection. If anti-HBC IgG is there, it indicates chronic infection. Anti-HBs indicates immunity. So it may indicate an old infection or an immunization. So if these anti-HBs levels drops, it means immunity is low. We have to take a booster of hepatitis B vaccine again. So we have hepatitis B vaccine available. Hepatitis C, the important points, everything is C. It is commonly associated with chronic hepatitis, commonly associated with cirrhosis, commonly associated with even hepatocellular cancer. When there is exposure to hepatitis B, there is a post-exposure prophylaxis, but there is no post-exposure prophylaxis in hepatitis C, but it is completely curable. Okay, so once we take a treatment for a regimen for a particular time, it is completely curable. So what drugs we give for hepatitis C? They are called as DIAC, directly acting antivirals. These are also called as pan-genomic. Initially, they used to classify hepatitis C treatment based on the genomes. Now the treatment is pan-genomic. So these drugs work for everything. So the important drugs to remember are drugs acting on NS3 protein, that is non-structural protein 3 is Teliprevir. Remember PR. NS5A, we have Velpatasvir, Daclofasvir, Ledipasvir. Non-structural protein 5B antagonist will be Sofosbuvir. B for B, just remember like that. The commonest regimen which we used is Velpatasvir plus Sofosbuvir or Daclofasvir plus Sofosbuvir. These are the drug regimens which are used. This is usually given for a time period of 3 months to 6 months, and they check hepatitis C RNA levels again. If it is low, it indicates cure. So this was about hepatitis viruses. Now the important concept of alcoholic hepatitis. In alcoholic hepatitis, always we must calculate Madrid's discrimination factor. That is 4.6 into change in prothrombin time. Change in prothrombin time is the patient's prothrombin time minus the control prothrombin time. So this difference into 4.6 plus the total serum bilirubin. If this value is more than 32, we have to give steroids. The steroid which is given is prednisolone. If prednisolone is contraindicated either due to a gastritis or some infection, then we have to give pentoxifylline. So both are anti-inflammatory. So it reduces TNF alpha levels and reduces further progression of alcoholic hepatitis. So MDF is used for alcoholic hepatitis, alcohol associated hepatitis. What is CTP score, child Turcot score, used for? It is used to stage chronic liver disease or cirrhosis. We have points from 3 to 15. 5 criteria are used, 3 points each. MELD score uses only 3 criteria. Remember BIC, that is bilirubin, INR, creatinine, BIC. This MELD score, it stages CLD as well as it was actually framed for liver transplant prognostication. Low MELD score is good for liver transplant. So that was about MELD score. What about APRI and FIB4 score? These are actually biochemical based scoring. So these uses APR is actually AST platelet ratio index. So it uses AST and platelets. FIB4 uses AH platelet, AST and ALT levels. So these are actually biochemical tests. When these are positive, it indicates that they may have fibrosis. These are usually used in patients with MASLD in PHC or GH settings to identify whether they have fibrosis or cirrhosis. If there is a fibrosis or cirrhosis, we should refer them for the next non-invasive test, which is fibroscan or tissue elastography. It's a non-invasive radiological scoring for fibrosis. We usually don't do biopsy nowadays to prove fibrosis. This tissue elastography or MR elastography is done. Now few terms about portal hypertension. Portal hypertension is portal venous pressure more than 10 mmHg. Remember, pulmonary hypertension is pulmonary arterial pressure more than 20 millimeters of mercury. So we have classified the causes as prehepatic, hepatic, post-hepatic. Hepatic causes may be pre-sinusoidal, sinusoidal or post-sinusoidal. The important pre-sinusoidal cause will be schistosomiasis. Important sinusoidal cause will be cirrhosis. Important post-sinusoidal cause will be veno-occlusive disease. The important pre-hepatic cause will be extrahepatic portal vein occlusion. So the name itself suggests extrahepatic portal vein occlusion, because portal vein is formed by splenic vein plus superior mesenteric vein. So there can be occlusion at this level. The post-hepatic cause is Budd-Chiari syndrome. The heart is also post-cardiac because IVC, the 3 branches of IVC hepatic vein join with the IVC and they enter the heart only. So any cardiac disease like restrictive cardiomyopathy, constrictive pericarditis, congestive heart failure causes cardiac cirrhosis. Now what are the complications of portal hypertension? Esophageal varices. Why this occurs? Because of portosystemic shunting. Because of portal hypertension, the blood coming from superior mesenteric vein and splenic vein cannot enter into the liver. So they bypass and enter the systemic circulation. They open the esophageal connection. Hepatic NSF. Because of this portosystemic shunting, the detoxified content in the portal vein enters the systemic circulation and they enter the brain and cause edema. Especially ammonia or glutamine, such substances cause brain damage. We have hepatorenal syndrome type 1 and 2. Nitric oxide is a vasodilator which is detoxified by the liver. When liver is problematic, nitric oxide circulates in blood, causes systemic and splanchnic vasodilation. When vasodilation is there, blood will not receive blood supply, kidney will not receive blood supply, so renal failure will go. The same vasodilation is the reason for hepatopulmonary syndrome. Hepatopulmonary syndrome, one typical feature is orthodeoxia syndrome. Platypnea, orthodeoxia syndrome. Platypnea is breathing difficulty on sitting position. Usually in heart failure, we have orthopnea, that is, there is breathing difficulty on lying down position. But in hepatopulmonary syndrome, there is platypnea, which improves when they sit down. So that is called as platypnea or orthodeoxia. So platypnea, orthodeoxia syndrome. And spontaneous bacterial peritonitis. That is when we do tapping of the ascites. If the absolute neutrophil count is more than 250 per millimeter cube, we call it as spontaneous bacterial peritonitis. These are the complications of portal hypertension. Commonest cause of portal hypertension is still cirrhosis. It is a sinusoidal cause of portal. Welcome to our channel. We are discussing last minute polls for NEET PG. We will discuss rheumatology now. So rheumatology is basically autoimmune diseases. So coming to organ-specific autoimmune diseases, think of myasthenia gravis. It is a blocking autoantibody against acetylcholine receptor, whereas Graves' disease is a stimulating antibody against TSH receptor. So the mechanism will be different for both. The best screening test for SLE. SLE is one of the systemic autoimmune disease which can affect any organ. We have ANA is the best screening test, ANA immunofluorescence. But what are specific for SLE is anti-dsDNA and anti-SM. That is anti-double stranded DNA and anti-Smith antibody. We can have many other antibodies also in SLE. They are anti-Rho, anti-La. Anti-Rho, if it is present in SLE, it is associated with neonatal SLE and complete heart block in newborns. But actually anti-Rho and anti-La, that is SSA and SSB, are associated with Sjogren syndrome. The SS stands for Sjogren syndrome. So anti-Rho and anti-La are actually associated with the Sjogren syndrome. How will you diagnose Sjogren syndrome? Sjogren syndrome is also a systemic autoantibody disease where there is lymphocytic infiltration of many glands, especially the salivary glands. So presence of SSA or SSB positivity plus minor salivary gland biopsy or lip biopsy showing lymphocytic infiltration literally proves Sjogren syndrome. Now coming to another autoimmune disease, which is systemic sclerosis. Now another autoimmune disease is systemic sclerosis. It is of two types, limited systemic sclerosis and diffuse systemic sclerosis. Limited systemic sclerosis, there is anti-centromere antibody. Diffuse systemic sclerosis, there is anti-SCL70 antibody, also called as anti-topoisomerase 3. Now there is a disease called MCTD, mixed connective tissue disease, associated with anti-U1 RNP. Now there is a disease called as APLA, antiphospholipid antibody, which is an autoimmune disease affecting the coagulation system. We have three antibodies in antiphospholipid antibody syndrome. One is anticardiolipin, next is lupus anticoagulant, third is anti-beta-2 glycoprotein. So usually this APLA clinically will present as repeated pregnancy loss, or there is arterial or venous or small vessel thrombosis. So presence of any of these plus two of these antibodies will be significant. Antibody, we have to have 2 times positivity in 3 months. Crest syndrome is a subtype of, or it's one type of limited systemic sclerosis characterized by calcinosis cutis, which is calcification of the skin, Raynaud's phenomenon, which is distal vasoconstriction of the digital vessels, which can cause digital ulcers, esophageal dysmotility, which can lead to aspiration pneumonitis, sclerodactyly, also called as sausage fingers, telangiectasia, may be dilatation of vessels either in the skin, nails or in the face. Now coming to joint involving autoimmune diseases, rheumatoid arthritis, the actual complete description will be it is an inflammatory polyarthritis. Inflammatory arthritis means there is early morning stiffness, pain on rest, which is relieved on activity. Polyarthritis is more than 3 joints, that is 4 or more joints involved. Rheumatoid arthritis affects small joints. Common joint effect is metacarpophalangeal and proximal interphalangeal joint. It should last more than 6 weeks. And the antibody which is positive here is RA or CCP. There can be ESR and CRP positivity. So the drugs used for RA, they are called as DMARDs. We have classical DMARDs and biological DMARDs. Biological DMARDs are the anti-TNF alpha inhibitors, interleukin-1 antagonist, etc. The classical DMARDs are hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Other points about rheumatoid arthritis is it is one disease which causes bilateral exudative pleural effusion. It causes bilateral exudative pleural effusion. Usually exudative pleural effusion will be unilateral. Rheumatoid arthritis causes bilateral exudative effusion, that too glucose will be very low. And it causes UIP pattern of interstitial lung disease in lungs. ILD, there are two types of pattern. One is UIP, that is universal interstitial pattern, or NSIP, non-specific interstitial pattern. Usually all autoimmune diseases will have NSIP pattern except rheumatoid arthritis, which has UIP pattern. Now coming to the next joint disease, which is ankylosing spondylitis. The earliest feature of ankylosing spondylitis is sacroiliitis. It is detected by MRI spine. Previously, bamboo spine was the finding which was detected in X-ray lumbosacral spine, but that is a late feature. Earliest feature is sacroiliitis detected by MRI spine. This ankylosing spondylitis is a axial seronegative. Seronegative means we won't get antibody positivity here. So axial seronegative spondyloarthritis. Psoriatic arthritis is another spondyloarthritis which affects the appendicular skeleton. Here distal interphalangeal joint is affected. Rheumatoid arthritis, PIP is affected. Psoriatic arthritis, DIP is affected. Plus there can be nail dystrophic changes. If you see the criteria for psoriatic arthritis, there should be DIP involvement, plus there can be a personal history of psoriasis or past history of psoriasis or even a family history of psoriasis. The next seronegative arthritis is Reiter syndrome or reactive arthritis. Reiter syndrome is a triad of non-gonococcal urethritis, large joint oligoarthritis and conjunctivitis. So conjunctivitis, urethritis and large joint oligoarthritis. Now we will discuss about vasculitis, that is involvement of blood vessel. Vasculitis will be large vessel, medium vessel or small vessel vasculitis. So among large vessel vasculitis, we have giant cell arteritis. It affects males. It causes headache. The joint pain or systemic symptoms in giant cell arteritis is called as polymyalgia rheumatica. Takayasu arteritis is another large cell arteritis, large vessel arteritis. It involves the subclavian artery, so it is called as the pulseless disease. In Takayasu arteritis, what is not involved? Coronaries are not involved because it is coronary is only a medium to small vessel. Takayasu is a large vessel. Kawasaki disease is a medium vessel vasculitis. We have two medium vessel vasculitis, polyarteritis nodosa and Kawasaki disease. Kawasaki disease is important in pediatrics. We call that syndrome as MCLN, mucocutaneous lymph node syndrome, because mucosa is involved, skin changes like skin peeling are there, lymphadenopathy is there. Kawasaki is important because it causes coronary artery aneurysm even in pediatric age. Now about small vessel vasculitis. There are many small vessel vasculitis. What is important to know is the quasi-immune vasculitis. That is, we have ANCA, that is anti-neutrophilic cytoplasmic antibody. These are specific antibodies which are found in diseases called as GPA, granulomatosis with polyangiitis is vaginous granulomatosis. Vaginous granulomatosis. In that we have CANCA. Then we have another disease called as EGPA, eosinophilic granulomatosis with polyangiitis, also called as Church-Strauss syndrome. Here P-ANCA is present. So C-ANCA, P-ANCA vasculitis. Now other type of vasculitis is Behçet's disease. Behçet's disease is a vasculitis also called as oculo-orogenital syndrome. So the criteria here is there should be recurrent oral ulcers. How recurrent? 3 times in 1 year. So recurrent oral ulcers plus some other features. There may be eye lesions, genital ulcers, and it is called as positive Pethergy test. Here the HLA-B51 is commonly involved. In ankylosing spondylitis, HLA-B27 is involved. Now coming to inflammatory myositis. In that dermatomyositis is very common, especially in pediatrics. The antibody involved in dermatomyositis is anti-MI2. Here there will be skin changes and muscle changes. Muscle changes is easy to understand. It is myositis, so there will be weakness of muscle. There will be proximal muscle weakness. Skin changes, we have many changes like Gottron papules, Gottron sign. heliotrope rash, V sign, shawl sign, etc. That is nothing but all the sun exposed areas will show violaceous rash. Now about crystal deposition arthritis, gout is very important. Gout is caused by crystals of monosodium urate. Uric acid doesn't deposit. Salt of uric acid, that is monosodium urate, gets deposited. Common joint is the first MTP joint or the great toe. So when you do a synovial fluid analysis, we can see the monosodium urate crystals, which are needle shaped, negatively birefringent crystals. This will be in contrast to in pseudo gout, where calcium phosphate gets deposited, where we can get envelope shaped crystals. So envelope shaped crystals are seen in pseudo gout due to calcium phosphate or calcium oxalate deposition. So treatment of gout will be symptomatic management is by NSAIDs and colchicine. Colchicine is an anti-inflammatory drug. How will you treat the disease or the pathology changing drug will be drugs which reduce uric acid production, that is xanthine oxidase inhibitors, allopurinol and febuxostat. Also we have other drugs like probenecid, which excretes uric acid, and we have some uricase enzymes, RAS uricase, which are used especially in uric acid emergencies like rhabdomyolysis, hemolysis or tumor lysis. In these conditions, when cells go for lysis, the intracellular uric acid gets excreted. So to remove this excess amount of uric acid, we use rasburicase. Welcome to our channel. We are discussing last minute polls for NEET PG. We will discuss rheumatology now. So rheumatology is basically autoimmune diseases. So coming to organ specific autoimmune diseases, think of myasthenia gravis. It is a blocking autoantibody against acetylcholine receptor, whereas Graves' disease is a stimulating antibody against TSH receptor. So the mechanism will be different for both. The best screening test for SLE. SLE is one of the systemic autoimmune disease which can affect any organ. We have ANA is the best screening test, ANA immunofluorescence. But what are specific for SLE is anti-dsDNA and anti-SM. That is anti-double stranded DNA and anti-Smith antibody. We can have many other antibodies also in SLE. They are anti-Rho, anti-La. Anti-Rho, if it is present in SLE, it is associated with neonatal SLE and complete heart block in newborns. But actually anti-Rho and anti-La, that is SSA and SSB, are associated with Sjogren syndrome. The SS stands for Sjogren syndrome. So anti-Rho and anti-La are actually associated with the Sjogren syndrome. How will you diagnose Sjogren syndrome? Sjogren syndrome is also a systemic autoantibody disease where there is lymphocytic infiltration of many glands, especially the salivary glands. So presence of SSA or SSB positivity plus minus salivary gland biopsy or lip biopsy showing lymphocytic infiltration literally proves Sjogren syndrome. Now coming to another autoimmune disease, which is systemic sclerosis. Now another autoimmune disease is systemic sclerosis. It is of two types, limited systemic sclerosis and diffuse systemic sclerosis. Limited systemic sclerosis, there is anti-centromere antibody. Diffuse systemic sclerosis, there is anti-SCL70 antibody, also called as anti-topoisomerase 3. Now there is a disease called MCTD, mixed connective tissue disease, associated with anti-U1 RNP. Now there is a disease called as APLA, antiphospholipid antibody, which is an autoimmune disease affecting the coagulation system. We have three antibodies in antiphospholipid antibody syndrome. One is anticardiolipin, next is lupus anticoagulant, third is anti-beta-2 glycoprotein. So usually this APLA clinically will present as repeated pregnancy loss, or there is arterial or venous or small vessel thrombosis. So presence of any of these plus two of these antibodies will be significant. Antibody, we have to have 2 times positivity in 3 months. Crest syndrome is a subtype of, or it's one type of limited systemic sclerosis characterized by calcinosis cutis, which is calcification of the skin, Raynaud's phenomenon, which is distal vasoconstriction of the digital vessels, which can cause digital ulcers, esophageal dysmotility, which can lead to aspiration pneumonitis, sclerodactyly, also called as sausage fingers, telangiectasia may be dilatation of vessels either in the skin, nails or in the face. Now coming to joint involving autoimmune diseases, rheumatoid arthritis, the actual complete description will be it is an inflammatory polyarthritis. Inflammatory arthritis means there is early morning stiffness, pain on rest which is relieved on activity. Polyarthritis is more than 3 joints, that is 4 or more joints involved. Rheumatoid arthritis affects small joints. Common joint effect is metacarpophalangeal and proximal interphalangeal joint. It should last more than 6 weeks. And the antibody which is positive here is RA or CCP. There can be ESR and CRP positivity. So the drugs used for RA, they are called as DMARDs. We have classical DMARDs and biological DMARDs. Biological DMARDs are the anti-TNF alpha inhibitors, interleukin 1 antagonist, etc. The classical DMARDs are hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Other points about rheumatoid arthritis is it is one disease which causes bilateral exudative pleural effusion. It causes bilateral exudative pleural effusion. Usually exudative pleural effusion will be unilateral. Rheumatoid arthritis causes bilateral exudative effusion, that too glucose will be very low. And it causes UIP pattern of interstitial lung disease in lungs. ILD, there are 2 types of pattern. One is UIP, that is universal interstitial pattern, or NSIP, non-specific interstitial pattern. Usually all autoimmune diseases will have NSIP pattern except rheumatoid arthritis which has UIP pattern. Now coming to the next joint disease, which is ankylosing spondylitis. The earliest feature of ankylosing spondylitis is sacroiliitis. It is detected by MRI spine. Previously bamboo spine was the finding which was detected in X-ray lumbosacral spine, but that is a late feature. Earliest feature is sacroiliitis detected by MRI spine. This ankylosing spondylitis is a axial seronegative. Seronegative means we won't get antibody positivity here. So axial seronegative spondyloarthritis. Psoriatic arthritis is another spondyloarthritis which affects the appendicular skeleton. Here distal interphalangeal joint is affected. Rheumatoid arthritis, PIP is affected. Psoriatic arthritis, DIP is affected. Plus there can be nail dystrophic changes. If you see the criteria for psoriatic arthritis, there should be DIP involvement, plus there can be a personal history of psoriasis or past history of psoriasis or even a family history of psoriasis. The next seronegative arthritis is Reiter syndrome or reactive arthritis. Reiter syndrome is a triad of non-gonococcal urethritis, large joint oligoarthritis and conjunctivitis. So conjunctivitis, urethritis and large joint oligoarthritis. Now we will discuss about vasculitis, that is involvement of blood vessel. Vasculitis will be large vessel, medium vessel or small vessel vasculitis. So among large vessel vasculitis, we have giant cell arteritis. It affects males. It causes headache. The joint pain or systemic symptoms in giant cell arteritis is called as polymyalgia rheumatica. Takayasu arteritis is another large cell arteritis, large vessel arteritis. It involves the subclavian artery, so it is called as the pulseless disease. In Takayasu arteritis, what is not involved? Coronaries are not involved because it is a coronary is only a medium to small vessel. Takayasu is a large vessel. Kawasaki disease is a medium vessel vasculitis. We have 2 medium vessel vasculitis, polyarteritis nodosa and Kawasaki disease. Kawasaki disease is important in pediatrics. We call that syndrome as MCLN, mucocutaneous lymph node syndrome, because mucosa is involved, skin changes like skin peeling are there, lymphadenopathy is there. Kawasaki is important because it causes coronary artery aneurysm even in pediatric age. Now about small vessel vasculitis. There are many small vessel vasculitis. What is important to know is the quasi-immune vasculitis. That is, we have ANCA, that is anti-neutrophilic cytoplasmic antibody. These are specific antibodies which are found in diseases called as GPA. Granulomatosis with polyangiitis is vaginous granulomatosis. Vaginous granulomatosis. In that we have cyanca. Then we have another disease called as EGPA, eosinophilic granulomatosis with polyangiitis, also called as Church-Strauss syndrome. Here P-ANCA is present. So cyanca, P-ANCA vasculitis. Now other type of vasculitis is Behçet's disease. Behçet's disease is a vasculitis also called as oculo-orogenital syndrome. So the criteria here is there should be recurrent oral ulcers. How recurrent? 3 times in 1 year. So recurrent oral ulcers plus some other features. There may be eye lesions, genital ulcers, and it is called as positive Pettergii test. Here the HLA-B51 is commonly involved. In ankylosing spondylitis, HLA-B27 is involved. Now coming to inflammatory myositis. In that, dermatomyositis is very common, especially in pediatrics. The antibody involved in dermatomyositis is anti-MI2. Here there will be skin changes and muscle changes. Muscle changes is easy to understand. It is myositis, so there will be weakness of muscle. There will be proximal muscle weakness. Skin changes, we have many changes like Gottron papules, Gottron sign, heliotrope rash, V sign, shawl sign, etc. That is nothing but all the sun exposed areas will show violaceous rash. Now about crystal deposition arthritis, gout is very important. Gout is caused by crystals of monosodium urate. Uric acid doesn't deposit. A salt of uric acid, that is monosodium urate, gets deposited. Common joint is the first MTP joint or the great toe. So when you do a synovial fluid analysis, we can see the monosodium urate crystals, which are needle shaped, negatively birefringent crystals. This will be in contrast to in pseudo gout, where calcium phosphate gets deposited, where we can get envelope shaped crystals. So envelope shaped crystals are seen in pseudo gout due to calcium phosphate or calcium oxalate deposition. So treatment of gout will be symptomatic management is by NSAIDs and colchicine. Colchicine is an anti-inflammatory drug. How will you treat the disease or the pathology changing drug will be drugs which reduce uric acid production, that is xanthine oxidase inhibitors, allopurinol and febuxostat. Also we have other drugs like probenecid, which excretes uric acid, and we have some uricase enzymes, RAS uricase, which are used especially in uric acid emergencies like rhabdomyolysis, hemolysis or tumor lysis. In these conditions, when cells go for lysis, the intracellular uric acid gets excreted. So to remove this excess amount of uric acid, we use RAS uricase.